Thank you, Christina. Good afternoon, everyone. On behalf of the Pennsylvania Department of Health, I'd like to welcome you all to the third session of the 2023 Pennsylvania LGBTQIA Health Virtual Summit, a series of live-streamed and in-person events taking place from March through June. I hope you'll join us on June 21st for the final event in this series, taking pride in tobacco cessation. The June event will highlight LGBTQ community efforts to push back against tobacco industry marketing. It will be held in person in Philadelphia and will be live streamed as well. You can please register for that at Bradbury-Sullivan.org, and I believe we'll be linking, listing the event page link in the chat for you to do that. So thank you again for joining us today. My name is Barbara Fickle. I'm the director of the Division of Tobacco Prevention and Control in the Pennsylvania Department of Health. Our program in our division are implemented by our partners across the state, including Bradbury-Sullivan LGBT Center, with the overall goal of protecting the public's health from the harmful effects of tobacco use. Our prevention program aims to prevent the initiation of tobacco use among youth and young adults, promote quitting among youth and adults, eliminate secondhand exposure to smoke, and especially advance health equity by identifying and eliminating commercial tobacco product related inequities and disparities. The Department of Health is committed to advancing health equity by understanding the tobacco industry predatory marketing tactics on certain populations. Tobacco companies spend billions of dollars each year to aggressively market their products. They also target specific populations, including the LGBTQ plus population, and flood them with commercial tobacco advertising. Marketing plays a big role in whether people try or use commercial tobacco products. Being around the ads makes smoking appear more appealing and increases the chance that someone could try smoking for the first time or start utilizing those products more regularly. Everyone deserves a fair chance and opportunity to be as healthy as possible. Achieving health equity means addressing systemic problems, unfair practices, and unjust conditions that have a negative effect on the health of specific groups. To achieve health equity, we work to eliminate the health disparities, and which are differences in health outcomes that are closely linked with social, economic, and/or environmental factors among the LGBTQ plus population. We are very happy to support Bradbury-Sullivan in supporting this, in hosting this important event, the Health Summit of 2023, as well as conducting a biannual LGBTQ health needs assessment in Pennsylvania. Results from the 2022 assessment highlight mental health as a top priority for this population. More support is needed for this population's mental well-being based on the survey responses. According to the CDC, smoking is much more common among adults with mental health conditions, such as depression and anxiety, than the general population. About 3 out of every 10 cigarettes smoked by adults in the United States are smoked by persons with a mental health condition. Addressing the important topic of mental health is our first speaker, Rahim Tawer. Rahim works as a psychotherapist, clinical supervisor, facilitator, and public speaker, lecturer, writer, and community organizer. He began working in the HIV/AIDS sector in 2008 and dedicated over a decade to LGBTQ Muslim community organizing. He was welcomed with an international visiting scholar, as an international visiting scholar with the South African College for Applied Psychology for the 2021-2022 academic year, and has taught as a lecturer at multiple universities in Canada. Rahim, thank you for joining us today, and now I'll turn it over to you.
Thank you so much for having me. I'm excited to be here today. As you mentioned, I am zooming in from just north of the border in Toronto. And even though I'm coming from a slightly different context, I believe that Canada and the United States have a lot in common. And so I hope that some of my findings and my reflections are useful to you. So I'm trained as a social worker, as was mentioned. My pronouns are he and him. I have spent a number of years working in LGBTQ communities, and in particular, my work has focused on queer guys, but today's presentation is broader than that. So I've labeled it I've called it same labels, different determinants. Now, the reason I've used this language is because I often subscribe to the social determinants of health model, which is about the different things that contribute to our overall health outcomes. And when I'm talking about things that contribute, I'm not thinking about individual things, I'm thinking about social, environmental, and systemic factors. So just like my straight counterpart could struggle with depression, I might also have depression. So we might have the same label, but what determines our experience of depression and how does our depression express itself? I'm going to argue that the drivers are embedded in a different social context. And as a result, they might also express themselves differently. So let's begin with the determinants approach. So when I talk about social determinants of health, I'm often referring to Canada's 12 social determinants of health that have been identified by PHAC, the Public Health Agency of Canada. I imagine the state of Pennsylvania or the United States of America also has a similar model. The 12 determinants are income and social status, social support networks, education and literacy, employment and working conditions, social environments and physical environments, personal health practices and coping skills, healthy child development, biology and genetic predisposition, health services, gender, and culture. Now, those are pretty broad, and I'm sure they're applicable in many places, and they can be adopted as common determinants of health. But what about mental health? What determines our mental health outcomes? I borrow from the CMHA here, the Canadian Mental Health Association. They've identified 3 significant contributors to mental health outcomes for all people. The first is freedom from discrimination and violence. The second is social inclusion. And the third is access to economic resources. Now, when I'm thinking specifically about mental health, I could also come up with a few more. But I want to switch gears to focusing on how we can adapt and why we need to adapt the social determinants approach for the LGBTQ context, both for physical health and for mental health. So first of all, we have our own past history of oppression and political persecution. Arguably, we still are under a regime of extreme persecution. That's not typically the experience of middle-class cisgender gay men, but our sisters and siblings in the trans community would say otherwise. They are currently under attack, and they have been for some time. There are also significant within-group disparities. So for example, I might be able to get a doctor that's gay positive, but I know that somebody who is poorer, somebody who is younger, somebody who is more gender expansive might have a much harder time getting equitable health care. They might also have, or not might, they likely will have a much tougher time making as much money as I might be able to. Education is inaccessible, the workforce is inaccessible, there's rampant discrimination and inequitable distribution of economic opportunities. Within our own communities, we have different liberation histories. For example, if we think about the last few years, there's been an uprising and a reckoning around racial injustice across North America. And many people in the LGBTQ community, particularly white folks, may have been surprised at the level of unsettledness within our communities. There's lots of divisive conversation. Lots of white folks couldn't appreciate how oppression was interlinked and intersecting for many people of color, and in particular, Black people and Black queer people. So while some of us have been made to feel like our liberation has been reached and achieved, we've forgotten about, or our privilege has allowed us to not consider how other people have been left behind. Within the LGBTQ community, there's also a wide range of experiences around representation and visibility. Who's at the policy table? Who is well represented in healthcare? Who has had experiences of being in legislature, etc. Within our communities, within each letter of the acronym, there are internal hierarchies of power and exclusion. In gay men's communities, we struggle with femphobia, racism, economic and class exclusion. We struggle with body fascism and exclusion based on deep-seated fat phobia, and we still struggle with HIV stigma. So each of the letters in this acronym comprises of a community that has its own internal hierarchies, its own layers of judgment, its own layers of stigma, its own embedded competition for power and access to resources. Within the queer and trans community, or LGBTQ plus communities, we also have varying perspectives on how we want to engage with mainstream communities, organizations, institutions, and legal bodies. For example, some queer people will say they want to get married and adopt children. And other people within the community will suggest that those goals recreate a kind of hegemonic, heteronormative idea of what it means to be queer in this world. I think multiple goals, multiple directions should be accepted and valid. However, we have to think about how the stress of internal community conflict affects us and how we also rely on internal community conflict and disagreement for political theory and imagination of ways to be in the world, how it emerges from our internal dialogue. So all conflict is not bad. Questioning of how we engage with the mainstream is also important so that we don't assimilate. And so that we also don't buy into broad homo-nationalist ideology. What the heck does that mean? Let me take a moment here. I remember in the last election when Hillary Clinton was giving just a phenomenal speech, and she talked about freedom for LGBTQ people. And of course, relative to President Trump, her speech was very good. Obviously, the intention was very good. But I get very wary of both Canadian and American efforts to equate national identity with progress, particularly when they equate it with progress related to LGBTQ communities. This is what's termed homo-nationalism, because neither country is actually progressive. Each country struggles with police brutality, surveilling of racialized and poor communities. Both countries struggle with gender wage gaps and gender disparity. Both countries have politics around the respectable, good gay or lesbian citizen and the degenerate, deviant, and resistant citizen. So I'm conscientious of the mainstream and how it wants to pull us in and take our money and wants us to champion its national identity and agenda. Hopefully I've made a good case for why we need to talk about the determinants of approach within the context of LGBTQ communities. I'm going to go through just a select number of determinants. I've come up with about 13, so that's maybe way too many to talk about in today's talk. But I want us to think about the developmental, social, familial, cultural, and political events that might mediate our individual experience. So for example, if I was to say, coming out is a unique determinant of our mental health, well, let's talk about what are the different layers that mediate that experience for each person. And let's recognize that there's no one right path through each of these determinants, right? One person could say employment is an important determinant of mental health. Yes, you could be employed and hate your job. You could be employed and really love your job, right? So the existence of employment presents some benefit, but it doesn't tell the whole story. So I want us to think about not a resolution. So if we say social inclusion or a sense of belonging is important, that's not going to look one way. There's many people who have vibrant social circles and feel very isolated. There's a number of people who have gym memberships and feel terrible about their bodies. There's many people who can afford to put food on the table and have a very difficult relationship with bodies and food. So it's not about resolving, it's more about contemplating how we move through the determinants, how we engage with them, and what are the factors that help support us as we engage with those factors in our environment. I'm going to put on the screen a number of social determinants that I see as being significant contributors and drivers of LGBTQ mental health. Now, I'll read through them, but I'm only going to really focus on the ones in bold today. So keep coming in, out, and around. Experiences of homophobia and transphobia. Our experiences of internalized shame. Our own experiences in our family of origin and our cultural experiences in those families. Our experiences of gender and grief. Our experience of body image. Drugs and alcohol. The overall landscape of connection seeking. Not whether you're in a relationship or not, but how you connect with people based on your desire to connect with people. Our experiences of multiple coming outs around gender, around sexuality, perhaps our relationship models or our polycules. Our experiences of accessing essential medical care and drugs. By that, I mean hormones, essential surgical procedures, HIV medication, etc. Separate from that is our ability to access accurate and affirming sexual health services, being able to manage rejection and endings in romantic relationships and friendships, particularly in the age of online dating, coping with aging in a culture that overemphasizes youthfulness, that doesn't have built into it some of the supports our straight counterparts have in their kinship models, and the dearth of services for aging LGBTQ people. There's also what I call milestone heteronormativity, and that is how we as LGBTQ people feel, experience, and interact with our straight and cis counterparts when they have their life milestones celebrated and acknowledged. Promotions, weddings, having children, buying property, having certain kinds of relationships or being afforded certain kinds of relationships with family and in-laws. These are some examples of things that we can have as LGBTQ people, but often our trajectories and our developmental experiences are different than our straight counterparts, especially after the age of 25 or 30. We enter a different area where we're creating our own map, and that map rarely gets recognized. And then we have our own experiences of boundary violations. What do I mean by that? Well, our cis and straight counterparts also experience childhood physical, emotional, or sexual abuse. However, they're less likely to have to worry about how that abuse might be connected to their own identity. They're less likely to have to worry that when they come out, people will think that their identities or the way they understand attraction is connected to a difficult past experience. We also don't have mechanisms or structures in place within our communities to effectively talk about abuse, consent, and boundary crossings when they occur in our own communities. Sometimes we feel guilt for talking about boundary violations because we feel protective of our communities and the people in them. So it's not to say that we are the only ones who experience boundary violations, but rather the way these get expressed and taken up are experienced differently in our communities. Let's talk about internalized shame. That's going to be one of the determinants I spend some time focusing on. So what is shame? When I think about shame, I'm thinking about a sense of inferiority, right? In a small sense, shame can be shyness, discouragement, stage fright. Shame can be embarrassment. Shame can be a feeling of defeat. But overarching shame is when we feel inferior. So why might LGBTQ people feel inferior? Well, the seeds are often planted at a young age. We often experience different kinds of childhood bullying, gender policing from family and communities, and we often don't know where we fit in. When I think about my own experience, I didn't know where I fit in at a young age as a result of being South Asian. My brown skin, the hair that grew on my body way earlier than my counterparts, the lunches my mom sent for me to take to school, all of these things made me very aware of my cultural background and my race. And I wanted to fit in with the boys, which has to do with masculinity. But I very much also wanted to be one of the white people. I wanted to be truly Canadian. And when I want to be seen like I'm of this particular place, what I've internalized at a very young age is that it's not as good to be from somewhere else. I also worried about effeminacy. So my inferiority or sense of inferiority kicks in when somebody else calls me a fag. I look back 30 years later and I'm thinking, oh, I guess that was useful information. Someone pointed out to me I didn't fit in before I realized that myself. But I also realized that I would have come to that acknowledgement myself when I was ready, and that I didn't need somebody to point it out in a way that was so violent, in a way that made me, for the next 10 or 15 years, very self-conscious about how I present in different situations. I was very hyper-conscious of what it meant to be around boys or other masculine peers, and the lengths I would go to be seen as one of the straight boys. So what kinds of toxic masculinity might I have adopted because I thought of myself as deeply inferior? Now, when we internalize shame, and we all have our unique sources, we begin to see ourselves through someone else's gaze, and we devalue ourselves. So I don't need somebody to put me down. I can already enter a space and a schema, an understanding of how white supremacy and rigid gender roles, they just get enacted in my brain. And I can evaluate myself according to that external system and its gaze. And it doesn't take long to evaluate myself as unworthy, unlovable, or disgusting. Do I feel like that all the time? Absolutely not. I am pretty amazing, as you probably already agree as well. But what I'm saying is that to recover from the seeds of this inferiority takes a long time. It takes a lot of support. It takes a lot of resources. And we all struggle with shame in unique ways. And that means that it can get activated in a number of settings. So what is going to mediate your experience of shame or your underlying sense of inferiority? I had said that mine were childhood bullying, gender policing, and being racialized in white spaces. If I think about what this looks like as an adult, mostly the world I navigate right now in a particular space in an urban center is less about my queerness and often more about my skin color. For example, I think about, if I don't tip enough, will it be attributed to my race? Or is it confusing for the people that I'm around to see a brown man with nail polish? I'm concerned about how race and sexuality come together and how that's experienced in different environments. So I would ask you to take a moment and think about your own sources of shame and what are those mediating experiences? You might be surprised that I'm actually giving you a minute, but that's only because I think it's worth thinking about. Let's talk about body image. Now, my experience of difficulty with body image comes mostly from cis gay men's communities. However, I know very well, being a therapist, that fat phobia is pervasive. So let's talk about this for a minute. What is fat phobia? When I think about fat phobia, I'm thinking about a culture that equates thinness with health. It equates thinness with discipline, hard work, strength, resilience, I think economic prosperity, perhaps. So those are just some of my associations, but you can think about how fat is thought about in your own context. Now, when I think about fat, particularly as it relates to gay men, I know that fat can also be feminized. So depending on how fat is distributed on your body, it might make a person very uncomfortable with themselves. It might lead to them being read as less masculine. Trans men or trans masculine people that I've known or that I've worked with have often talked about the concerns around the distribution of fat that they experience while also having a beard and navigating gendered spaces, particularly spaces frequented by cis gay men. What does our culture tell us about food? On the one hand, if you have access to food, it should say that you're part of a minority of people in the world, and you should be very grateful. However, many of us have such a disrupted relationship to food because being able to control what we put in our bodies comes with the possibility of being envied by our social circles. It shows restraint and diligence. It also is a function of class. To be able to drink the green juice and have a membership at the fancy gym versus eating fast food or having to have convenience meals that you heat up in a microwave. Exercise, unfortunately, is one of the only ways we seem to understand health and well-being. What about supplements? What about spending time with people? What about positive self-talk and therapy? What about spending time with pets or sleeping when you really need to? What about taking days off work when you feel anxious in the same way you would if you had a cold or a flu? I think we desperately need to expand our idea of what wellness, both physical and mental, is in our current culture. Unfortunately, the rhetoric around self-care can or has the potential to fuel our disruptive relationship to food or with food and can reinforce fat phobia if it becomes about dedicating more time to the gym. So when I think about people's motivations to change how their body looks, and I see a lot of this in my therapeutic practice, and I'm not talking about trans people seeking gender affirming surgeries. I'm talking about people who want to go on diets or engaging with strong messages around diet culture, and people who want to exercise or are really hard on themselves for not exercising more. I'm thinking we need to have some really clear motivations about why we want to change our body or what we want the outcomes to lead to. For example, in my therapy practice, when I talk to people about their motivations for exercise, what we eventually come to is this idea or a fantasy, perhaps, that they will then be closer to other people. Other people will like me. I'll get more responses on Tinder. I will go on more dates. I'll have a more vibrant social life. My friends will introduce me to other people. And while that may be true to some degree, because of course, fat phobia is real, what gets missed is that diets and fluctuating weight doesn't cure anxiety and doesn't necessarily support increased comfort with intimacy. It might bring you closer to people, but it might bring you closer to people in a superficial way. People often bond around food and beverages in social settings. And if you have a difficult relationship with food, how will you socialize? Will you begin to think about your romantic partners and your friends who you longed for so long as being barriers to your wellness plan, which is defined in a limited way as exercise and diet? So I want us to think about the experiences that we all engage in that are leading to some kind of body change. And I don't think anyone is 100% body positive. I think we operate in a culture that makes it difficult to be both body positive and not have any judgments toward ourselves. But what happens when those two things come together? When I say, I love your body as it is, I'm just really hard on my body. Well, what happens is that we shut down the possible conversations about the pervasive culture of fat phobia and how there is a parallel between hating ourselves for being queer and trans and hating our bodies for the weight it carries. I know diet culture has many manifestations. In my cis gay world, I find that Pride has always been a difficult time of year. And I've come to think about Pride, which I once thought was a liberating time filled with liberating spaces, as also being potentially harmful. And I pause here to think about all the time I spend fighting for my community that then creates spaces that make me feel bad about who I am. How do I navigate that? And when I look around and there's a party full of men with six packs and pecs, what are they trying to accomplish? Is that a defense against their internalized shame? And are they burying their femininity in muscles? Are they recreating toxic masculinity? I see trans men often aspiring to a lot of the same ideals as their cis gay counterparts. And I'm thinking, what communities are we enabling? And how do we talk about the difficult position we're in when we want to dismantle something that's harmful and painful, but we also want to be able to participate in it? In the same way, a lot of us want to dismantle capitalism, but we still need to be able to participate in it. And it makes me think about all of us who were bullied for our gender when we were younger, or our gender expression. And is it simply safer to be femme if we're muscular, or safer to be femme if we're devoid of fat? Take a moment here and think about how body image maybe affects you in your life, how it shows up, how it plays out in conversations with your friends. How does it make you feel when they talk about their diets or their cheat days or whatever keto something or another they're doing? Does it bring out envy? Does it bring out comparison? Does it make you feel ashamed? Does it make you angry? Do you compartmentalize very well and think, hey, that's for them, it has nothing to do with me? Let's talk about substance use, drugs and alcohol. So on the one hand, if you describe drugs and alcohol as social lubricants, they have a very clear connection to our wellness, right? We want to be connected to people. We want to feel a sense of belonging. Something that's called a social lubricant is going to make a lubricant reduces friction, right? And so we're going to have more seamless social encounters. There will be bonds that are created. There'll be threads and quilts that are woven. And we will have social safety, and we'll have community, and we'll have chosen family. Nobody consumes drugs or alcohol because they want to have an addiction or because they want to conjure up difficult memories of the past. But our relationship to drugs and alcohol can change over a number of years. And difficult feelings can start to come up, particularly when we rely on drugs and alcohol as a facilitator of connection. In those moments when we feel rejected, or we feel alone, or we have a bad trip, our minds go to different places, and different themes and thought patterns seem to come to the surface about neglect, isolation, our own unworthiness, our negative feelings about ourselves. Do we have built-in trauma supports in our community? How do we understand the connection between substance use and trauma? In my mind, the connection is very clear. Substances are something that lots of people want. Altering the way we think about the world and altering our experience is a universal experience that lots of people opt to explore. For a number of people, drugs and alcohol can become a problem. But I can also think about problematic drug and alcohol use as an adaptive trauma response. And I'm thinking about how we can create a culture that doesn't individualize addiction or individualize the experience of difficult relationships to drugs and alcohol. Are our treatment plans and our health service systems designed to support community connection, to heal family trauma, to heal the wounds of homophobia and transphobia that are now internalized homophobia and transphobia? Are they designed to address the grief around gender and failing gender? Or are they designed to make us think about structured relapse prevention in an individualized fashion? A recovery model built on individual will and discipline and a commitment to change. How do we balance some of those things? Now, when I think about LGBTQ communities and substance use, I would say that our socially sanctioned parties exist way longer and in many more iterations than our heterosexual and cisgender counterparts. What I mean by this is that we can all think about our college or varsity experience where it's normal to binge drink. Like for your health, it should never be necessarily normal to binge drink, but at certain times in our lives, we see it as more appropriate. I think about my straight cis counterparts who went away to university and then moved back home with their families, and then went and got jobs or started dating. They got married, they had kids or maybe didn't have kids. In many ways, the party stopped for them at a certain time. For queer and trans people, a lot of us kept going to the bars. That's how we connected with one another. We saw endless drag shows, we performed in them, we hung out at the bar on Sundays. All of our celebrations happened at the bar. Our mourning and grieving happens at the bar. There's just a lack of sober spaces. And we feel anxiety about even entering a sober space because we're not sure how we'll connect with people. And that becomes really difficult. I think our individual relationship to substances can quickly change. And different kinds of drugs come with different stigma. For example, somebody who can afford cocaine is seen as having money and having enough resources to bounce back. Economically, that might be true. Support-wise, not always. Within our own communities, there's stigma around the differences. There's different approaches and conceptualizations when somebody struggles with drinking versus when somebody is injecting meth. How do we flatten this hierarchy so that we can talk about what drugs and alcohol, regardless of what they are, what they do for us, what they facilitate, and when they become a problem? And how can we prevent further social isolation when somebody does identify a problem? And then in the context of substance use, in the places where we find community, perhaps, where we find safety, perhaps we engage in sexual play or, rave partying, whatever it is. How do we think about creating new safe mechanisms within those spaces? I don't want to say that you have to toss out all of the friends you made or toss out the communities where you use substances. Maybe you do struggle with substance use, but that community might have meant a lot to you. But how do we change it so that you don't re-experience that moment where somebody used too much GHB and you witnessed them, you were a bystander when they were sexually assaulted, or when you saw somebody pass out at a party or an after hours club and they were abandoned by their friend group? How do we shift those moments of difficulty and isolation? I'm interested in making our drug using spaces kinder, whether individually we decide to continue staying in them or not. Now, I want to talk about relationships, but it's not really just relationships. I think about it as the landscape of connection seeking. Oops. Now, why do I call it this? Because I don't think that being in a relationship or not being in a relationship or having casual sex or not having casual sex makes you a better person. You're a good human just the way you are, right? But many of us come out into a community where casual sex is equated with a kind of liberation, a kind of politic around who we want to be in the world. And so I might say, how do each of us, if we're in the community, understand casual sex? How has it been taught to us? What have we been told that sex represents? For example, for some people, a sexual encounter through a hookup app or online dating, it might represent achievement. For others, it might represent social participation, as in that's the way they get to connect with other people. They talk about their sexual experiences. It might also be that people have sexual experiences that then turn into friendships, or that then turn into relationships that then turn into friendships. Sexual encounters, particularly brief encounters, might also have rewards for self-esteem and self-validation. Being able to have casual encounters with people you desire and who desire you can be experiences where we repair some of the wounds of an injured masculinity, where we once thought we weren't enough, we weren't man enough. It can be very affirming, but also it can help us heal shame, anxiety, and it brings us into contact with some other difficult things. So for example, when I think about what mediates experiences of these brief encounters with myself, my friends, the clients I work with, often there's a struggle with the dominant culture's messaging and the subcultural messages around what casual sex means. In dominant culture, people often, I think, we get messages like casual sex is something you do before you settle down. It represents recklessness. It means immaturity, for example. It means unconstrained, undisciplined lust. It means sinfulness in some cases. And in our subculture, it might mean something very different. Now, in our subculture, I'm hesitant to say that casual sex is all liberation. It also comes with lots of difficulty. When I think about meeting men for casual sex on online dating apps, for example, or at bars, parties, I'm faced with white supremacy, femphobia. I know lots of my trans and non-binary friends are faced with transphobia. So people explicitly will say who they're not interested in. And those of us who are a minority within a minority are then confronted with messages of normalized exclusion, normalized diminished worth. And because we've all been socialized in a dominant culture, we might also have value conflicts. So we might have anxiety or shame about seeking casual sex, even if it's something we want. And then is born the phenomenon of many people who come to the sexual health clinic with low objective risk, but very, very high anxiety, who think that they have a sexually transmitted infection or they contracted HIV, not because they've objectively put themselves at high risk, but because after their encounter, they're filled with judgment and shame about the kind of sex they sought and what it says about them for having engaged in that kind of sex with that quote unquote type of person in that particular setting. The landscape of connection seeking is not just about brief encounters, of course. It's also about romance and partnerships, so dating and anything that's longer term than that. So it makes me think about attachment style and wellness, or our awareness of attachment styles. So as queer and trans people, we often experience rejection earlier in life. We anticipate rejection from our families and our communities, and we often generally feel left out in many social settings. Some of us might even report differential treatment in our own families. How does that affect us long-term? How does that show up in our relationships? How does that conversation get taken up? And who is there to support us to have that kind of conversation? How do we identify and explore subcultural norms around attachment style? So for example, as a cis man, I know that being avoidant is actually rewarded. If I can connect with somebody briefly and then detach, that kind of avoidance is seen as normalized and it's rewarded because we socialize men to detach in that particular kind of way. We say, oh, that's just how men are, as opposed to more accurately saying, oh, you detach quickly. Perhaps you've become really good at compartmentalizing because that is a function of how you learned about masculinity. And if I feel particularly connected to somebody, is that attachment to somebody labeled as anxiety? Is it labeled as drama? Is it feminized and stigmatized? Then I think about, in general, what it means to be a romantic minority and how that affects our well-being. Are you alloromantic or allosexual, aromantic, asexual, demi-romantic, demisexual, etc.? Are you also part of a romantic minority community where you openly think about your relationship orientation as being open or poly? And do you experience lots of stigma for that? Is that something you can't talk to your straight counterparts about? So what are some of the mediating experiences that are going to impact our well-being? Well, it's going to be our community norms. But who is our community? Who are the people we surround ourselves with? How do we talk about relationship models in a way that's not stigmatizing and that's both outside of our community and within our community? I'm finding in my practice that open relationships are being embraced by a number of people, but as it becomes more the norm, there's more complexity around talking about what we hope to gain from openness and what we hope to gain from monogamy, and how do we nurture and support both of these experiences. Okay. I'm gonna end on sexual health, but I'm not gonna go through it as in depth. One thing I want to say is that as a gay man, I've been messaged too heavily around HIV. And in some ways that's good. In other ways, I've had to think about fear and equated that with sex much earlier on than any of my straight counterparts. One point that I want to draw home, or that I hope that we can think about further, is how we have completely forgotten about or overlooked queer women in all of our sexual health messaging. And when we've talked about HIV, particularly in the global north, We have somehow adapted to include trans men, but have left out trans women. And so lots of sexual health resources and testing centers, maybe not today, but for the better part of the last 35 years, have left out trans women. And there's been clear experiences and replications of trans misogyny and how HIV has been handled. I'm going to return to these determinants of health so you can take a final moment and just have a look at them. I could speak to each of these, and you could probably share some additional experiences that add to each of these. Thank you so much for having me at this Health Summit. You're welcome to join my mailing list at tinyurl.com/follow Rahim. If you want to follow me on social media or invite me for any kind of talk, you can get my details at ladyadavan.com. Thank you so, so much.
Thank you so much. We so appreciate having you with us and being able to benefit from your expertise. I know we've had a few folks ask about closed captioning. We're having difficulty enabling that, but thank you for bringing that to our attention. I'm going to briefly introduce myself, although if you've attended other sessions, this isn't the first time you're seeing me. I am Christina Graham, pronouns she, her, and I'm the Data and Evaluation Manager at Bradbury-Sullivan LGBT Community Center in Allentown, Pennsylvania. And today, as we've done in the previous sessions, I'm going to be sharing with you some selection of data from the 2022 Pennsylvania LGBTQ Health Needs Assessment. And in keeping with our theme today, I'm going to focus mostly on the data we've collected around mental health experiences. A brief background on the assessment. The biennial survey was first piloted in 2015-2016 with the first statewide survey in 2018, and the assessment collects data on LGBTQ Pennsylvanians' experiences with a number of health and wellness areas, including their experiences with healthcare providers, their mental health, substance use and tobacco use, cancer prevention and incidence, sexual health, financial security, food insecurity, and more. And the findings from this assessment are then made available to researchers, healthcare providers, government agencies, and what is really the most important, it also goes back into the hands of the community, starting with the organizations that help collect the data. Data collection is led by a coalition of more than 40 LGBTQ community-based organizations across the state who share it with the local communities they serve, allowing us to reach as many folks as possible. For the 2022 survey, we collected data between January and March with 4,228 responses being included in the final data set. So that is LGBTQ plus folks from across the state. Some highlights from the 2020 data collection. There was improved coordination in the use of promotional materials. Data collection partners, that 40+ set of organizations, received weekly updates with tips and information to help them direct their promotion. We had targeted promotion for our younger community members, older community members, our BIPOC folks, Asian Americans and Pacific Islanders, and our Spanish-speaking LGBTQ community members. And we had improved outreach, including more materials and dedicated partners that were able to share those with our communities. We added a new demographic option, allowing folks to identify themselves as being Middle Eastern or North African, in addition to a variety of other what are considered standard options. And that's something that we're always looking to improve. And then there were some new topics. We were able to include COVID-19. The 2020 survey was collected during lockdown, so there wasn't time to add those questions. So we were happy to get those in this time around. We also asked brand new questions about being neurodivergent or autistic, living with a disability, and about sleep quality, among other things. So let's dive in. I wanted to start with barriers to care. We asked respondents, sometimes LGBTQ people do not access mental health services because of barriers to care, and there was the option to check all barriers that applied. 45.4% of respondents selected at least one of these options. 15.6% reported that they could not find LGBTQ affirming mental health providers for the care that they need. About 1 in 10 reported that LGBTQ affirming mental health providers were too far away for them to access. 12.4% reported that LGBTQ affirming mental health providers were not covered by their health insurance. Nearly 16% feared a negative reaction upon disclosing LGBTQ identity with a mental health provider. 8.2% reported other barriers that was a write-in option. And so just over half didn't report any barriers. But clearly this affects a significant portion of the community. This varied by location in the state. Being too far away from a provider was more common among rural Pennsylvanians. But clearly there are barriers that prevent folks from seeking mental health care when they are in need. Rahim talked a little bit about how experiences of discrimination really affect the mental health of LGBTQ folks. About 41% of our respondents, both respondents of color, as well as transgender and non-binary respondents, reported that they had experienced discrimination based on LGBTQ identity at any point in their lives, compared to about 60% of white non-Hispanic respondents and about 56% of cisgender respondents. What I wanted to do today in looking at the data was that's one of the areas I wanted to focus on. In previous sessions, we've broken down the data by some other demographic factors, but I thought today it would be interesting to look at what were the mental health experiences of folks who had reported experiencing discrimination in their lives. And the other factor I wanted to look at, because I felt that it would have an impact on what you might experience in your mental health wellness, was feeling respected in your LGBTQ identity. Although about more than half of respondents reported that they often or always feel respected in their LGBTQ identity, those experiences are less common for our respondents of color, as well as transgender and non-binary respondents. And we do see respondents who never or rarely feel respected in their identities, likely meaning that they don't have significant support in their lives. And we ask this question for a variety of groups: feeling respected by your neighbors, your birth family or family of origin, your coworkers and classmates, your friends, and members of your household. So I've grouped together first those who have experienced discrimination, and as well as those who reported not being respected in their identity. 3 in 4 respondents overall, out of that 4,228, had experienced a mental health challenge in the previous 12 months at the time they participated in the survey. And that was even more likely to be true for folks who had had lifetime experiences of discrimination or who don't feel respected in their identity. Following up from experiencing mental health challenge, we asked about receiving mental health treatment, including counseling or medication. Just over half of all respondents had access treatment. That was pretty similar for folks who had experienced lifetime discrimination, but less of our community members who are lacking respect in their lives had access mental health treatment, about 40% compared to half. I want to take a moment to share some resources, including the National Suicide Hotline, the Trans Lifeline, and the Trevor Project Lifeline, all of which are 24-hour hotlines. Because I do want to spend a moment talking about experiences of self-harm and suicide among our respondents. 48% of all respondents have ever had thoughts of self-harm. This is extremely high and something that I think both medical providers and community-based organizations need to be aware of. And that was even more likely for those who had experienced lifetime discrimination, although it's pretty close. So 48% for overall, 50.4 for those who had experienced discrimination, and 40% for those who felt that they were lacking respect in their daily lives. We also asked respondents, have you ever had thoughts of suicide? With just over half reporting having had those thoughts at some point in their lives. 54.4% of those who had experienced lifetime discrimination have also had that experience, as have 39.3% of those who are lacking respect. Rahim talked about companionship and how that is a significant factor in folks' mental health. About a third of respondents to the survey reported that they were often or always lacking companionship compared to sometimes or never. This was also true for about that same number, about 1 in 3 of folks who had experienced discrimination, but was true for more than half of those who do not have the respect they need from the folks that are around them. About 1 in 3 also experienced feeling left out often or always. Again, true for just over 1 in 3 of folks who had experienced discrimination based on their LGBTQ identity. And again, over half for those who don't feel respected in their identity. Isolation, as well as other mental health concerns, including depression and suicide, are often the experiences that community members are most concerned about. We ask all respondents of the survey to select from a list, what are the 3 top concerns for the LGBTQ community? And this is one that has come up in several past iterations of the survey. 38.1% of all respondents report that they often or always feel isolated. This was even higher for those who had experienced lifetime discrimination at 41.6%, and even higher at 60.8% for those who reported low average respect. I also wanted to talk about feeling stress related to your LGBTQ identity, as some of these experiences, anyone could feel isolated. And I'm certain that in both our 2020 data collection period and continuing even now, there are folks that, due to the COVID-19 pandemic and other factors, are isolated from their social connections that they had before that. So I wanted to look specifically at asking respondents, how frequently did something happen related to being LGBTQ that left you feeling stressed or upset? 21.8% of respondents reported that this had happened often in the previous 12 months. This was true for 27.0% of those who had experienced discrimination and 43.0% of those with low average respect. So almost twice as common among those who aren't respected by the folks in their lives as it was among all our respondents. And I wanted to wrap up with the data, looking at the differences between those who often or always receive the social support they need and those who rarely or never receive the social and emotional support they need. So about 42.9% of our all respondents said that they are receiving support, which is something that we found very encouraging and highlights some of the resilience factors within Pennsylvania's LGBTQ community. Support from peers, from local organizations can be critical in your daily wellness. 40.5% of those who had experienced discrimination reported that they do receive support, as had about 1 in 3 of those who were lacking respect. About 1 in 5, however, do not have that support. That's also true for 22.9% of those experiencing discrimination and 36.5% of those experiencing low average respect. I want to offer this as a critical point for those who are in community-based work and can provide spaces or peer-to-peer support. At our location in Allentown, we have quite a number of peer support groups, as well as groups that are identity-based. Being able to provide those spaces is a very critical avenue to giving people the support that they need and creating space for companionship and connection. I encourage you to check out the full report, and I'll share a QR code for that in a minute. But I wanted to address the recommendations that we share on pages 53 through 55 of the full report, and specifically highlight those that I think are relevant to this topic. The first is supporting connections to LGBTQ competent providers. Being able to access the treatment you need from a competent provider is critical in how well that treatment goes. Identifying community-wide mental health supports, such as safe places that people can gather, and having folks feel represented and spoken for in their wider communities. Specifically, boosting community supports for our BIPOC community members, and for those who are in the position to do so and provide some of these critical resources, whether it's through your expertise or funding, partnering with LGBTQ community-based organizations, as they are the most likely to know what their local community needs. Please check out the full report. If you have not read it already, you can access it at that QR code or at bit.ly/2022HNA. And next, I'm going to leave the slide up just so that everyone can see the organizations involved in making this event possible. But now I'd like to take a moment to introduce our community moderator who will be moderating the Q&A. Dr. Tawer Titus, pronouns they, them, is a licensed professional counselor, former president of Erie City School Board, and the founder and board chair of Compton's Table. I asked Tyler to join us today, as Compton's Table is one of the data collection coalition, and Tyler kindly lent their face and their wide social media following to help support the health needs assessment, which as part of the project team, I'm so grateful for. Dr. Titus became the first openly elected transgender official in the state of Pennsylvania back in 2017, and then served 2 consecutive terms as the co-vice chair of our nation's first LGBTQ Commission of Affairs under Governor Tom Wolf. They regularly present at local, state, and national conferences on topics of systemic inequity and how to create inclusive spaces for historically oppressed individuals and communities. Over the past decade, Dr. Titus has trained over 8,000 teachers, guidance counselors, support staff, elected and appointed officials, and community leaders across our Commonwealth on decentering cishet perspectives and identifying mechanisms of oppression that continue to inflict harm on the queer community. Tyler, I'd like you to be able to take a few minutes to speak about yourself and your work, and we're so grateful to have you with us today.
Yeah, awesome. I'm not super stoked to follow both you and Rahim. I feel like the information that was presented was just astounding and phenomenal, and I have a whole notebook full of new notes to incorporate for myself as a provider and as somebody who's trying to break down some systemic barriers as well. But my name is Tawer Titus. I use they, them pronouns. I'm up here in Erie, Pennsylvania, right by the lake. And basically what I do is a little bit of too much without any real self-care mixed in. I'm currently running for office, but my favorite thing that I get to do is run Compton's Table. We are a nonprofit organization that officially opened our doors in 2020. And then the pandemic hit. So we were primarily virtual for the first year and a half of our existence. But what we focus on primarily is reducing suicidality amongst queer youth between the ages of 12 to 24. When I was completing my doctorate program through the University of Southern California, that was where I had focused. Just my research was around, that we continue to see things not trending in the correct direction, right? We still continue to see youth, especially those who are gender nonconforming, seriously contemplating, attempting, or taking steps to end their life around a 50% rate, right? And so I saw that statistic. I couldn't stay quiet about that statistic. And so of that was my action was Compton's Table. we do things here around, we're primarily focused on getting youth connected so that they can be in social spaces together, right? So we'll rent out arcades, we've rent out the art museum, we had a huge back to school drive, we've done youth drag shows. And so it's just a lot of fun stuff where we're empowering youth just to get to be youth and enjoy one another. And that's my absolute favorite part of all of this is when I'm like, this is so overwhelming. All the work is overwhelming. The stats are depressing. I come into our space that I'm sitting in right now, and these youth are playing Switch or they're just being silly and they're laughing. And I'm like, this is why we do it. And so with all of that, this is, you know, why I absolutely jumped on board and said we have to do this, because data is absolutely critical when we are trying to create any type of solutions or maneuver through anything that's going to make our spaces and places and ourselves and our lived experiences different, right? And so with all of that rambling, I would like to kind of open it up to some of the questions. I did see that Rahim was already, you know, answering some of the questions that were kind of asked, which is great. I love it. One of the questions, Rahim did a phenomenal job right there in the chat and kind of spelled it all out. But as I was jotting down notes very quickly, one of the things that I kept coming back to was something that both you, Christina, had highlighted and Rahim had touched on during their talk. And I guess whomever would like to jump in to answer or expound on this is, we talked about the inequity within the inequity, right? So seeing that some of us within the queer community are facing these oppressions and hardships even harder. I'm curious if you could, one of you could speak on, or both of you could speak on, specifically to our trans community with who are Black, Brown, Indigenous, how we're seeing this in the data. Like, we know that we're facing it harder, but what are we seeing long-term those impacts showing up as?
Since you said the word data, I'd love to jump in first. I think something key here is that we can't address those inequities if we're not measuring them. I think a lot of what we see in the health needs assessment first comes from our community-based organizations, from testimonials, from the people that we interact with, organizations saying, I see a problem for the people I serve. Where do I go next? And that is something that informs many of the questions that we ask, including the new questions that we asked about disability and neurodivergence. And I think then putting that back in the hands of the folks who understand the issues best. I immediately think of one of the organizations that works on the project, Sisters Pittsburgh. You know, if I'm asking how do I better serve BIPOC trans folks, who better to ask than an organization led by and for that community? They have the lived expertise, they have the understanding, and creating an inclusive space where people really see themselves, they need to be leading that effort. But then I think also doubling back and being able to present to organizations with power, organizations with resources, being able to say to providers, this is a gap in your knowledge, and we need to close that gap. And then Rahim, I'd love to hear your thoughts.
Thank you. It's a complex question. I think that we are in a unique time where some people in our community have gained quite a bit of mobility, like upward social mobility. And some of those folks are very aware of the ongoing gaps in our community and the disparity, while others are not. And so I would say that, like, there needs to be some education for people who think that we've made it and that other struggles are not, like, who don't see our struggles as shared. I think there needs to be some education around that. Alok Menon, who is a fabulous non-binary trans activist, they said, they put out this reel not too long ago where they were talking about how the marriage equality lobby was full of, you know, mostly capital G, capital L, gay and lesbian people who, like, were able to lobby, and they had so much social influence and so much capital. Like, they were able to make a thing happen. But where are they when we need to, like, when like trans people are being targeted and when Black people are being killed by police, they're just like nowhere to be found, right? So I think we need to get people on board. We need some of those allies, but we also need like some mentorship programs within our community that help. Like, I see a lot of programs where like people living with HIV, we've got like a food security program, or we've got this meal trans program at the community center, but like we need more for people who are marginalized within our communities. Like, we're giving them things that are like, here, you can survive, but like, what about growing? What about like meaningful opportunities to thrive, you know? A few years ago, I was running a support group, or I was helping create a support group for queer folks struggling with substance use. And on the poster, we had put prioritizing Black and Indigenous folks. And so many white queer folks were like really upset by that. And it was disheartening, because we what we wanted to say was, you are also welcome. We're just letting other people who might have felt like this institution wasn't for them, we just want to let them know that like they are welcome, and we're prioritizing their needs, etc. And so we're in a tough time. I think we've had this assumption for a long time, or we've had a fantasy for a long time, that if somebody experiences marginalization, they will somehow understand somebody else's marginal experience. And that's just a dirty lie. It's not true, unfortunately. It's more like, oh, I want a bit of access to privilege and power, and once I get it, I've forgotten about learning about how other people don't have that. So I know that's not a clear-cut answer. I came out with mentorship program, but I'm thinking about ways to create opportunities within community is what I'm really thinking about.
I'm going to chime back in. I think work like what Compton's table is doing, things that are what I would call disruptors. Before youth are where so many other members of our community are right now, you're creating space for joy and hopefully mitigating those problems that we might see down the road. Hopefully, but it's tough out there, and to keep programs like that running is not an easy task. And I think the long list of things you're personally doing shows why that happens, because the people that are speaking up are often speaking up in multiple places, and your resources end up being stretched thin. I think events like this are also really important. Therefore, we've got a lot of folks from government agencies on the call that are providing direct care, or are working somewhere in between, that they help facilitate connections between community organizations and the organizations with resources and leverage. And I encourage people to think local. Take a look at what's happening in your local community. We have such an incredible wealth of community-based organizations here in Pennsylvania. But that's also true other places. I know we have folks on the call that aren't from Pennsylvania, but I think that's a model that can be replicated. Go outside and take a look around. And like I said, ask them what the problems are. They already know, and they might even have an idea of what's needed. They just haven't been able to get to it, whether it's lack of staff, lack of funds, political interference, whatever it may be. They might already have the answers.
I think these are great answers, and it kind of led in a little bit to my next question. But I can't help but share something sometimes when I'm in these spots as well too. One of my professors had, and it just stuck with me. Like one of my first classes. Was the very first time I ever had a Black educator was when I reached my doctoral program. I had never had a Black teacher. I had never had a Black professor prior to that, right? And so I think when we think about going back to both what Rahim and Christina said is there are some who are climbing up, right? But there are many who have not benefited for some of the movements that we've had in here, even though the foundation was laid by Black, Brown, and Indigenous people. And so even though we have all as a community benefited, When I walk into spaces, for example, I'm white first, I'm able-bodied first, and I'm very mask presenting. And so I know the privileges that I'm afforded because of that. And my one professor had just said, nothing for us without us, but never given charity what is owed in justice. And I think so often it's very easy to say we're doing a food drive, or we've donated $1,000, or we've done this thing and now we've done Pride. We marched in the rally. Those are all great things, but they are a Band-Aid, and it's not stopping, the gushing wound of, what the data really outlined for us against suicidality, intravenous drug use, the lower lifespan, the fact that, Black trans women aren't supposed to, statistically speaking, make it out of their mid-30s before, harm comes to them, which results in at the end of their life. So I think, there were so many data points and stuff here that we kind of talked about, addressing the inequity within the inequity. But I'm a big fan of also leaving people with, okay, so now what? So now what do I do? And you both highlighted some action steps, but I want to break it down a little bit more clearly if we could. Specifically for those who are within the community, somebody who identifies as queer, what are things that they could do to help uplift the other members of the queer community? And then what are some things those who are allies move from that ally into that, an accomplice, into that activated stage?
I've heard that called co-conspirator, which I
love the
kind of
co-conspirator,
like.
yes.
Recently when the World Cup games took place, and soccer players were not permitted in Qatar to wear the rainbow armband. Some people were so mad. They were like, what the heck? This is an international organization. They should be canceled. And I was like, okay, sister, let's slow down here for a minute. Like, I am not that interested in these random soccer players performatively wearing a rainbow band. I'm more concerned about the labor violations and the human rights violations that took place and the people who died to create the stadium and make it happen. So I think we need to be very cautious about not buying into superficial things around representation and inclusion. Like, I think we should maybe commit ourselves to one thing that affects us directly and one thing that is like a broader issue, right? And food security, affordable housing, poverty reduction. Honestly, everybody deserves that. It doesn't matter if you're homophobic or transphobic or whatever. Like, you deserve those basic things. And then society can ask more of you, but we can't rob you of like basic dignity and then penalize you for not being socially progressive in the ways that we want, And I think we really have to think about the nuances of some of this. And then I thought about the World Cup, and I was like, I don't watch any soccer, but I was in Belgium at the time, and I saw on the screen after certain teams won, people were waving a Palestinian flag, and I was like, this is all very complex. This thing was born on the backs of poor people and migrant workers. And now there's some advocacy for a state that's not otherwise recognized by most of the world. Like, there's some complexity here. So I want us to sit in the complexity and not evaluate things on the surface. There's lots of big banks. Every Pride, it breaks my heart when I see a bank that has showered its front exterior in the Pride flag. And I'm thinking, how much did it cost you to do this? And then there's like a lot of people who are under housed or maybe homeless with tents or little spaces in front of that Pride flag or in front of that bank. And I'm thinking, man, who are they including? Who is this for? Who is this party for even, And so I think we need to think a bit deeper about just bigger issues that have to do with everyone's basic dignity and human right.
When I think about ways that the community can build community for themselves, find out what local programming is available to you. And I know what people often think of first is like when you say, how can I get involved? You're talking, how can I donate? How can I volunteer? But those programs thrive on people showing up. Just show up. In a year, we will be collecting data again for the health needs assessment. 15 minutes of your time multiplied by the thousands of people who participate is invaluable. And that 15 minutes contributes to research that I think of as buy-in for the community that goes so far. And that project has come a really long way in just a few years. If you can volunteer or donate, like I said, if you know, when I say resources, that might mean money, that might mean time, that might be just your visible support. I think back to when we were working on the health needs assessment, and I reached out to what we kind of called prominent folks around the state. And we were like, Tyler, will you put your face on this? And you very kindly said yes. Because we knew that, especially in your local area, that's a key point to people. That's a cue that this is for me. And I think whenever you're in a position to help someone else understand this is for you too, that can be a really powerful thing. We're coming up on the end of our time. I also think participating in things like this. So thank you to everyone who was able to join us today. Just by being here, I think you're saying, I care, I want to know more. I know folks are jumping off, but thank you so much for joining us. I'm really looking forward to the last event, so stay tuned for more information about that. And a few folks had asked about the recording. Eventually, all the recordings will be up on the landing page in place of where the registration links were. And thank you so much for being with us. I know both Rahim and Tyler have big social media followings, so follow them because they're always sharing the really great work that they're doing. So everyone have a great day. Thank you for both of you for being with us. Thank you, Barb, for your welcome. And I look forward to seeing everyone in June.